This is one episode of a three-part series based around education and information for school-based telehealth. To see the other episodes, follow the information in this video's description. This series of videos was designed to provide educational content for federally qualified health centers and rural health clinics to assist with their telehealth implementation. The content is also useful for other types of providers and organizations. The following video will cover these specific topics.
Hi, everyone. My name is Kristin Kase. I'm the Nurse Practitioner Manager for Student Health Centers. We're from Multnomah County Health Department in Portland, Oregon.
My name is Leslie Gellert, and I am one of the integrated behavioral health providers for Multnomah County School-Based Health Centers.
Just a really quick oversight before we get into the nuts and bolts of our telehealth work that we've done. I just want to say something about our program. We are in 5 school districts. We have 9 centers. We're an FQHC. Our model is that we're in the high schools, but we serve K through 12 kids, and they come to the high schools. We are a full primary care model, which includes contraceptive methods, integrated behavioral health. We actually have separate co-located mental health who pre-COVID lived in our clinics with us, but was a separate model in a separate department. They now are 100% virtual, and we'll talk about some of what we found from that. And then we do COVID screening on site, no out-of-pocket costs. We also have a majority of our clients are Medicaid.
So just a little bit about integrated behavioral health. We are licensed clinical social workers, so we're independently licensed and paneled with multiple insurances, both private and state insurance. So this is how we recoup some of our costs through billing. We have same-day access, Monday through Friday, and in-person video and through the telephone. And what integrated behavioral health does is a brief assessment of biopsychosocial needs to inform the treatment plan. So we do a lot of skills-based intervention. We do assessment of mental health conditions, and we also do, care coordination and chronic illness co-management with the nurse practitioners, such as with asthma, ADHD, diabetes, depression. And then we also support when a client or family is not ready to engage in mental health therapy, so longer-term services. We help support them to walk alongside to just support their health.
So this is our timeline in response to the pandemic. And so this just really helped us take pause to look at all that has happened in the last 8 or 9 months. And prior to late March, we were open at 8 sites. We were supposed to, in the midst of all of this pandemic, open our 9th site, and that is on hold right now. So prior to late March, we serve about 6,000 unduplicated clients. The other thing I need to set the stage for is we have an electronic medical record, which is Epic, which became key for us as we had to shut down. The third thing I wanted to kind of put the highlight to is we are still in virtual learning. So we started in virtual learning and we continue with virtual learning, and we are not certain when kids are going to come back on campus. They are actually on campus for socially distant conditioning for sports, but January we'll hear we have no idea what's going to happen with on-site versus virtual learning in our area. So going back to our timeline in late March, as I think most sites had to do, is we had to go down to 1 health center for our area, and I'm assuming this is other areas too. We had to conserve PPE. We advocated to keep 1 site open logistically in the facilities because we are a primary care medical home, and for us to have to refer kids that needed on-site services to one of our primary care clinics or to an outside provider just seemed really disruptive for the family. So we really advocated to go down to 1 site. And with our Epic electronic medical records, it made it pretty seamless that we actually had access to all their records. So that happened in late March. And of course, as with most people did, we pivoted to mostly telemed. And when I say telemed in this sense, it's phone visits. So we went all to phone visit, and if people needed to come in, we actually triaged them in through our phone visits. So we always had access to bringing clients in if we needed to on person, because there's some visits, honestly, we have to see in person. We also had 2 teams. So we rotated 1 on-site team every week was on-site. The other week, they were doing 100% telework with telemedicine. So it really increased our access for our telemedicine. So that was in April, and it was all phone visits. And you'll see, we'd been doing phone visits before. And we'd been pushing for video visits, which hadn't happened because of technology and workflows and maybe functionality with Epic. But in May, they were able to, and this is one thing I've seen with COVID and how flexible and adaptable sites and programs can be when they have to be, we were able to launch video visits within about 2 months of really working on it. So starting in May, we were able to offer video visits and phone visits. And then in June, and so we really were keeping most of our clients out, and we were only bringing them into the clinics as they needed to. So we really did not focus on wellness. We didn't do wellness, of course, not immunizations. But in June, we really started relooking at that, and we decided to kind of start to really readdress our wellness care and our immunization needs because they were getting behind. And we also started offering COVID testing. So we had to develop all those protocols around COVID testing and parking lot testing and triage around that. So that happened in June. So really, we kind of hobbled along through the summer with one site open with some backup telemed. And then it became clear probably end of July that we were going to still be doing virtual learning. I think, there was so much uncertainty. We were like, oh, we're going to open up all our sites because all kids are coming back. And then the school districts called it. So then we were able to advocate with this other 2 school districts who really wanted us to open 2 more sites. So we geographically looked at our BPOC population, our free and reduced lunch, our geographic area, and that's how we navigated our 3 sites across our city. And from that time, we really have been trying to promote with our schools, our counselors, with care coordination, lots of virtual outreach, a lot of virtual meetings in classrooms to let kids and families know that we're here. And we've gotten busy, and you'll see some of our slides around our numbers. And then we're hoping to open 2 more because our numbers have spoken that there's a need for on-site services. Kids and families are requesting that. So we have created the numbers in the story to be able to hopefully advocate for more openings in 2 months. So just really quickly, our evolution of telehealth. So we did a pilot a number of years ago, and Alex Lowell, who's actually on as our program manager, she actually spoke at a national convention around our pilot, where we actually had telehealth carts. And we were in a school, one of our underutilized K-8 schools, and we had the RN presenting to a provider at a different site to see if our clinics were not sustainable, our provider numbers were done. So it was just a real trial to try to see how that would work. And we did some really nice evaluations, and we found a couple of things. First of all, we were not really sustainable. And so that was one lesson that we needed to learn. But the other thing that was really important to us is we got input from families and kids around what did this feel like with the telehealth cart. And it was positive. Like these kids and families really were good with doing virtual visits. So that was really good information as we started to move forward. So then we closed those sites and we didn't really do much with those telehealth carts. But we did expand the option for phone visits. So we were already doing phone visits. So we knew the billing, we knew the documentation, and we were hoping for video visits at some point. And then thank you, COVID. COVID helped us with that one. So what happened is, in March, we went down to the phone visits. And then in May is when we added the video visits and expanded them. And our video visits, the main platform is we have Zoom through our Epic chart. And so that has been the way that we've initially tried to do it, is have kids. And we'll talk about some of the barriers around that. But it also is pretty awesome when it works. So then we were able to expand. We were able to get okay for FaceTime and some of these other venues, at least during COVID. I don't know if that will continue, but my favorite still when the kids and families can get on is Zoom through Epic. And the other thing that we've added in September is Leslie. We've always had halftime behavioral health in person, and it was always at one site. And now we've expanded to 3 sites, and we don't have Leslie at every site all the time. So what we've done is we have iPads in our clinics. And so when I'm in a visit and I need to do a warm handoff in the clinic, I'm able to roll in the iPad and Leslie pops into the visit. So it's not the same as her being there, but it's pretty close. So the iPad is in there, and then they have their visit with the client in the exam room when I need to do a warm handoff. So this is our numbers story. And so I want to walk you through this because this really does, it's a lot of lines, but it actually tells our story. And it was, again, thank you, Alliance, for helping us do this, because this will help us share our stories to other people as well. So when you look back in January, look at the lines. The blue line is on-site visits, and the red line is phone visits, and the yellow line is virtual visits. So this is apples to oranges at some point, because in January and February, you're really looking at 8 sites providing. So it's 1,600 visits. And as you could see, phone visits very low, on-site very high. That was our immunization exclusion month, so it's one of our busy months. So boom, March happened. We went down to 1 site, and as you can see, our red, which is our phone visits, went up above our blue, which is our on-site. So we were doing many more during, especially March and April, we were doing many more telephone visits than on-site visits. So, and we really stayed like that actually through June at some point when we then, I think there's a number of reasons why we actually started changing over in June. But when you see May, we started doing our video visits, still relatively low. And I have some thoughts about that because that's an important thing to kind of really figure that one out. But we really stayed even through the summer. And then in September, we opened up 3 sites. And our in-person visits went up significantly. The need and the desire and patient-centeredness for us is telling us that families are ready for on-site, and we still do phone and we still do virtual, but our on-site visits are definitely going up the curve right now.
I think one of the most telling thing about these slides is the comparison between the behavioral health and the medical visits. They start with the medical visits, it starts with January and February. And so we don't see on this slide, we don't see necessarily January and February, but we start in April. So there isn't this sharp drop that you notice with the medical visits. But one of the clearest indications for us is just that dip in visits, and then starting in August and then moving into September, we see this uptick in total visits, and then also uptick in video visits, and then telephone visits as well. We hope that this trend will continue, and I anticipate that the trend will continue with virtual visits and with telephone visits and also with on-site visits. Kristin?
So essentially, our behavioral health providers have been more, for a number of reasons that we're still figuring out, have been more successful with video visits than our medical providers.
This is how we get paid and cover our costs. We have a unique situation where the state of Oregon School-Based Health Center Support Office gives us a grant that pays for approximately 70% of the salary of the integrated behavioral health provider. We also receive fee-for-service reimbursement, and it's approximately about 30% using behavioral health billing codes. We also have an added funding source, which we don't really know what it's going to look like. It's going to be a smaller amount where our coordinated care organization provides a per member per month incentive when we meet SBHC or depression screening metrics for their member population receiving Medicaid coverage. And due to COVID-19, Oregon allowed for flexibility regarding telehealth as well as billing parity for in-person telephone and video visits. We know that video and telephone visits will receive that continued parity through December. We don't know what it's going to look like after, but we're hopeful that it will continue and that this will not just go away.
We've been told that video visits will retain the same level of parity, but we're worried that phone visits might go down. And that's another reason why we really need to kind of do a deep dive in our video visits.
So behavioral health access options, there are many different ways that kids can access behavioral health. We can do warm handoffs in person, through the phone, or video visits through FaceTime or Zoom through Epic. I just got off about an hour ago from a FaceTime warm handoff in the clinic, even though I'm at home. So that happens periodically throughout the day. We can communicate with clients via MyChart, via texting. We have introductions from school counselors, from Google Meets, and through email. And then we also have self-referral, where clients can just call up and schedule or somehow get connected so that they can get an appointment. Next slide.
So this is just the venue of different options, and we've gotten pretty techy and we've gotten pretty flexible. And Leslie's been one that she's on her phone, she's on the computer, she's in person. And so the options have really expanded for us as far as how kids are accessing us. So really quick, the opportunities, and some of this I want to just put out have to do with video visits. When I say improved assessment of client interactions with families, increased client engagement, really seeing their home settings, their bedrooms, that's all about video visits. On Friday, I did 4 video visits and I got introduced to 2 of the animals, cats and dogs. So that's just been great. It also really is giving us options around client preference and comfort. And the other thing is, now that we're across the city, kids that had a student health center close to their neighborhood now don't. So just really expanding the ways that they can touch base with us has just really helped us make those connections. And then again, that flexibility piece. Challenges, and I think Allison alluded to technology limitations for the families, like the Wi-Fi, and also some of the challenges of getting on, especially when there's language barriers. We actually have interpretation on our Zoom, but sometimes it's just even the challenges of getting on can be overwhelming. I feel like, this is my assumption, I feel like there's some provider discomfort with video visits. And so that's some of my work as a manager to really kind of dive deep into that to try to really encourage, because my assumption and my view is I feel like video visits are superior to phone visits. I think it's challenging to sometimes complete our screening forms, even though we can send them out on email. And of course, metrics. You can't do an HPV shot if you're not there. So really looking at that as far as challenges. And again, setting up for video visits can be a little bit challenging. And as Leslie would say, it's not always the same experience. In fact, on Friday, Leslie and I shared a 13-year-old with anxiety, and we'd done it in person. We said, would you like to video? Would you like to come in? And the kid and the family wanted to come in. So we keep hearing that. And I think that's why our mental health is underutilized, because they're not having the options to bring kids in. And until you ask that question and give them that option, you may not hear that really they're virtual all day long here. And so making a human connection has seemed like it's been an important thing for kids.
This series of videos is presented to you by the National Consortium of Telehealth Resource Centers, the NCTRC. The NCTRC is funded through the U.S. Department of Health and Human Services, the Health Resources and Services Administration, and the Office for the Advancement of Telehealth. This map represents the NCTRC, which covers the whole United States and includes 12 regional TRCs and 2 national TRCs, which are the National Policy TRC and the Telehealth Technology Assessment Center. The TRCs have been in existence since the early 90s and were established to provide assistance, education, and information to organizations and individuals seeking information on providing healthcare at a distance. The NCTRC mission is to expand availability of healthcare to underserved populations through telehealth. For more information about telehealth, the NCTRC, one of the 2 national TRCs, or your regional telehealth resource center, please contact us through the NCTRC website. Thank you for joining us in reviewing this video series.